Ladies and gentlemen, you know that dengue has emerged as the fastest growing infectious tropical disease. Few years back, we only heard of malaria when we talked about a disease which was linked to a mosquito. But now the dengue has emerged as a new threat. It is a threat to the health system. It's a threat to the economy because the hospitalization rate is high. And it is very important to have innovative solutions for dengue surveillance and control to prevent this disease and to invest in the different systems and softwares which can help us improve the control of this disease. For this very reason, our second speaker will be talking to you about innovative solutions that have helped in dengue surveillance and control in Pakistan. I'm very honored to introduce our second speaker for today, Captain retired Muhammad Usman Yunus. He's from Pakistan Administrative Services, and before that, he was serving in the army. He has served in Punjab, Sindh, and Gilgit and Baltistan provinces of Pakistan at very impactful and important positions during his 29 years of service and career. He is currently serving as Commissioner Lahore Division. Previously, he has been the honor of having the longest serving DCO of Lahore, which speaks volumes of his skills and leadership quality. He has championed the cause of public health throughout his career, as during his tenure as District Coordination Officer in Lahore. In 2014, he successfully managed the dengue epidemic, then again in 2015-16, and last but not the least, in 2019 in Rawalpindi, when he was acting as Secretary Primary and Secondary Healthcare. It is under his dynamic leadership that we were able to curtail this dengue epidemic, which is reported to be one of the biggest epidemics of the world. I'm very pleased to introduce Captain retired Muhammad Usman to you, presently serving as Commissioner Lahore Division, and he will be talking to you about innovative solutions that we have adopted for dengue control program in Pakistan. Captain Usman, please.
And thank you very much, Dr. Somia, for a very elaborate introduction. And to all the participants around there, first of all, I'd like to congratulate Dr. Waseem for a very wonderful, insightful talk on vector management. I have a lot of slides to show to you in how innovative solutions were brought in dengue surveillance and control in Pakistan, and particularly in Punjab. So I'll try to be as elaborate as possible, but I'm sure you must have a lot of questions when we go along. Now, to start with, when we talk about dengue has now become a global problem. And over the past few years, we have also experienced that dengue has an international perspective. I mean, 2019 was a bad year for nearly the whole world. So while there is a relationship with weather, there is a relationship with tropical countries being, contagious to each other. Dengue is now giving us information on account of international boundaries as well. I mean, we need to learn from each other's experiences as far practically as possible, and that's how is the case scenario in Punjab, particularly, where we have made a lot of corrections and alterations to our original dengue program that was conceived in the year 2011. Coming back to Punjab has had the worst epidemic in 2019. We nearly saw about 10,000 confirmed patients last year. And this was for the first time that each district of the province reported a dengue case in 2019. I mean, it had never happened before. Previously, there used to be cases in some districts. There used to be kind of epidemic in a few districts and very little cases in a few districts. And majority of the districts never reported any case. In 2019, every district of the province reported a case. Now I'll brief you about how we have institutionalized everything. I will talk about hospital readiness. I will talk about awareness. I will talk about how reporting systems have evolved. And I will talk about how we keep a track of insecticides and then evidence-based decision-making, involving the citizens on how to do it. We have a third-party validation system as well. Everything revolves around surveillance, and everything, kind of supplements or complements the surveillance regime that we have in the province. And this did not happen automatically. There is a complete timeline of about 9 years before you that will tell you that how we learned through these methodologies and how we improved these methodologies. For the first year, we just introduced a helpline. Second year, we had a vector surveillance system. Then we also introduced a dengue tracking system in the year 2012, which was improved in the years 2014 and 15 respectively. Then we had a patients reporting system in the year 2012. Clinical practices guidelines was first issued in the year 2012, and then subsequently improved and revised every year. Dengue SOPs were formulated in 2014 for the first time, and then revised for the second time in the year 2020. We have brought in a couple of legislations to ensure that the surveillance is well protected under the existing laws. We have a third-party validation system. We have a dengue virus report, and then last but not the least, we have also involved the general practitioners into adding on to the case management reporting system through a GP's application, which was brought about last year. Hospital readiness is about the dengue expert advisory groups advisories, and they have reporting forms. There's a clear-cut dengue counter layout established in our hospitals. If you go to a hospital, there is a layout. You will get to know that the counter is just not a single counter. It's a series of counters where different activities are taking place for a particular dengue patient. And this just did not happen automatically. We have gone through a lot of rehearsals and through a lot of hit and trials to kind of improve upon this dengue reporting system in our teaching hospitals. The data reports that come into our system or to the central system are through the teaching hospitals, through the district headquarter hospitals, through the THQs, and then through the BHUs and RHCs. Subsequently, there is this tracking system where a patient's demography, workplace, clinical information, laboratory information, other details are mentioned, so that we have a baseline to start. We also have a disease surveillance wheel where in all the hospital management systems, we have an information flowing in on what type of disease is at the moment kind of reporting more patients or not. This is a wheel that will tell you that there's a code is automatically sent to everyone to you exactly know on a particular date which disease has reported how many number of cases. Now, coming on to the GP's case reporting mobile application, it's a simple mobile application where the general practitioner only tells us information about what is the name of the patient, what is his or her address, the other clinical details, so that the case response management regime can come in. Now, after we have information and we've collected these data sets, then we have a surveillance and response management system. This is surveillance and response management system has flown in, it kind of gets developed through the patient reports, the health line, and the mobile application. There is a field network of operators that work through these mobile applications, and they carry out surveillance of different activities. The application is very user friendly because most of these people who are using this application are not very literate. So these applications are very user friendly with symbols and signs instead of a lot of data written onto it. The surveillance happens through this application. The users of these applications are very familiar with these applications. We kind of keep revising these applications, and a lot of trainings happen on ground to make people familiarized with how to use these mobile applications. Each application the application has a hotspot earmarked for everything. Every activity that a user performs can be categorized in a particular data set that's contained in the application, and then this information that flows through this application on the dashboard is then eventually analyzed to see what is happening on ground in a particular larger cluster of areas. For instance, now on this slide, there's a set of activity that on the left side on the month of launch, only 300 activities were performed, and in the next month 1,574 activities were performed in the same area. And likewise, if you see towards the right side, 92 million activities were performed in the year 2021, in the last month actually. So that's how this anti-dengue application has flown. And in a particular area in the province, only 300 activities were performed in the month of launch, and now nearly 92 million activities have been performed up until 2021 and 270 million activities to date. This is how these activities are performed. The user takes a picture before performing an activity, and then after that activity is performed, another picture is taken and it is uploaded into the system. Likewise, these activities then eventually result into showing Bretto index of a particular area, whether there are cases from a particular area and how many houses in a particular geographical area are reporting how many number of containers that are positive. So that it brings us to issuing Bretto index alerts for those areas, so that more vigil can take place on ground in those particular areas. Evidence-based decision-making happens, for instance, in the month of May 2021, we ensured through these reporting systems that every complaint on the health line was resolved, case response of every patient was done, and the complaints that arrived on the DVR, about 97.5% complaints were resolved. And likewise, we have identified hotspots that we need to clear within 7 days of a particular cycle. So 98% hotspots in the month of 2021 were cleared. We also carry out analysis of how districts are performing on ground. For instance, this is a slide that tells you the districts who reported cases, and all of those districts, since it's 100%, we have carried out an analysis that all of those districts have performed case response with respect to the residence of a patient that got reported from that district. Now, this is about indoor surveillance. All of these activities that are carried out in the particular indoor setting of a resident or of an area are reported on the dashboard, and hotspots are generated on account of how many number of larvae are being detected in a particular area. Likewise, this is just an example to tell you a particular area of Lahore where the number of patients in a particular area is mentioned, as well as the number of activities that happen on ground. So you can correlate if the number of activities are commensurating with the number of patients that get reported from that area, or the activities are lesser and the areas are ignored. So this is for the people who are analyzing these data sets to find out if actual monitoring or surveillance is happening on ground. Similarly, in a case of confirmed patient, we have a policy which Dr. Waseem Akram also highlighted, that we carry out IRS in 49 houses. We have a policy of clearing 49 houses around a particular area where a patient was reported, not only his or her workplace, but also his or her residence. So through this application, through this geotagging, we also find out if it's clearly happened on ground or not. Likewise, the evidence-based reporting also identifies a lot of flaws into the system. For instance, this is a patient that got reported in the month of July 2019. When the patient was reported, we found out on the left side that comparatively very less Android activities were performed 10 days prior to the patient that got reported into that particular area. Likewise, the larva tagged in the epidemic region prior to 15 days was also very staggered and very few. So this kind of indicated that while this patient got reported from this epidemic area, the surveillance was not happening accurately and larva was not being detected in that particular area. So that's how evidence-based reporting, kind of tells you in advance whether you're doing things correctly or not. Now, these are also some incidents from 2014 where larva incidents has been reported and a confirmed patient incidence has been reported, where the activities are subsequently, when they are performed, they are geotagged on the application also. The occurrence of larva also kind of can tell you how an early outbreak information can be obtained, and I'm confident that Dr. Somia will take up this issue in her subsequent talk today. We also introduced a third-party validation system. This system is very good as long as you don't monitor it. If you stop monitoring it, if you stop finding out what's actually happening on ground, that these data sets do not actually work anymore. So we have an audit for every larva that gets reported, and we have an audit for every patient that gets reported, and we also have an audit of all of the other activities that are happening, the surveillance activities that are happening. So there is a third person who actually goes to the ground on a place where larva was reported and clearance was kind of conducted on the application. So a third person goes there and finds out if the larva was there or if sufficient activity was performed or not. This has proved to be a very useful application on account of finding out how our people are working on ground. Likewise, the DVRs that get reported onto the system, they're also cleared through the application. There's a separate application that reports these DVRs. There's a geotagged location that gets reported into it, and people go onto the site and remove those debris or whatever obstruction has been reported. The insecticide availability is also digital. It's just not that somebody reports whether insecticide is available or not. Every district has a central reporting system of what insecticide is available and what is the expiry of that particular insecticide. One of the most important aspects of our entire operation is the citizen engagement that we have. We involve a lot of we have this helpline where people complain through the telephone. Over 800,000 calls have been received on account of chemical control, fogging, cleanliness, polio vaccination, cleanliness, IRS requests, tire complaints, ponding, non-availability of medicines, measles, overcharging of any diagnostic facility, water supply, and other patient counseling, as well as complaint logging reports. This is a toll-free number, by the way. Similarly, we have this hospital feedback application where a patient, while he or she gets discharged, can also kind of tell whether he or she is satisfied with the clinical arrangement that were made for him or her. Likewise, he or she can also tell us whether somebody consulted his house for surveillance for case response. A lot of information through awareness has to be dispelled every year. Every year on the onset of rainy season, on the onset of monsoon season, we have to make a lot of social media campaigns, robocalls, mass SMS, and healthline messages also. This is the physical evidence of how activities in different cities get conducted during the onset of monsoon or rainy season, so that people kind of are aware of the ensuing danger. There's a rickshaw driver who's being distributed a pamphlet in one of the slides, and in other slides, people from different walks of life are carrying out walks to tell the public what's important to be done with respect to this current season. Now, when we talk of institutionalization, there's a very strong network of engagement tools that we have right from to the topmost level. There's a central emergency response committee meeting that happens at the chief minister level, who is the chief executive of the province. Then there's a cabinet committee meeting that nearly happens every week during the onset of monsoon. Otherwise, it happens at least every month or bi-monthly throughout the year. There are district emergency response team meetings that happen usually about 2 to 3 times a week. And then there is town emergency response committee meeting that happens nearly, again, 2 to 3 times a week. So these meetings are documented. Every department, every agency that's involved in the surveillance attends these meetings, and any on-ground issues are resolved. And this is a very, very interactive session, and it's a very regular feature of our entire surveillance regime. Then we have critical technology interventions. There's a weekly report. There's a report issued by PITB to all districts where hotspots, their dengue virus report by special branch, case response, increased incidence of larva, indoor surveillance details, smartphone activities, containment activities, and third-party validation activities are reported to the districts through a written communication as well. Then there is a system-generated daily patient alert also, that how many patients have reported from what all districts in the province. So there's a complete SMS there that gets issued to all people that are involved in the tracking as well as surveillance. Then there are special daily reports that are issued on account of confirmed patients as well as the surveillance activity. This is a special report, cyclo-style, to include all those districts that are vulnerable in a particular time frame, given time frame, and details about hotspots, details about activities, details about Bretio index, details about patients, how many suspected, probable, or confirmed patients have been reported. And likewise, these are special daily reports that are sent out to all who are involved in the decision making. Likewise, we also have weekly reports, which is a very, very technical report, which is issued through a committee consisting of WHO. We have an Institute of Public Health Management, then the King Edward Medical University Specialized Healthcare Department, and our PITB. These are weekly SITREP reports that are issued to all stakeholders so that they are abreast of what is happening. Now, this is a huge network of activities that happens across the province, and dengue is a very, very serious issue right here in this province. And the impact that we have achieved over the years is that in 2011 we have nearly 311 deaths, and in 2019, which was kind of another epidemic that had the entire province into its gulf, had 45 deaths. Otherwise, the number of deaths reported every year has been under 10. So that's I think that's an achievement that this entire public health management service that we have in place has brought about considerable decrease in the mortality of this disease. By the way, 2019, as I earlier mentioned, also has witnessed a very bad epidemic in Pakistan, where Islamabad reported more than double cases from Punjab. Islamabad, by the way, is a very, very small city with respect to geography as well as population. And Punjab, which is the largest province, reported about 8,600 patients, while Islamabad reported 14,543 patients, because they did not have as elaborate system in place as we have in Punjab. Thank you.